Hello, good afternoon, and welcome to Oceanside Library's afternoon program with Northwell Health Cats Institute for Women's Health and sponsored by Assemblywoman Missy Miller. We're so grateful for this partnership, and also to celebrate National Women's Month, we thought it would be appropriate to have a Wellness for Women workshop. It's a very important topic, one that we all need education on every year. It's a good idea. So we thank you so much for partnering with us today. I now would like to introduce our presenter for the day, Dr. Rosemarie Conigliaro. Take it away, Rosemarie.
Thank you so much. So it's my pleasure to be here and talk to you ladies and maybe gentlemen about women's health, which is an important topic. And I appreciate being asked by the library and the Congresswoman to speak on behalf of Northwell and the Cats Institute for Women's Health. What we're going to talk about today are several things. The first is empowerment. And what I hope you take out of this talk, if nothing else, is that you are in charge of your health. Even though your doctors and your other providers play a role, it's really about you. And so when you go to see the doctor or a provider, or even the pharmacist or a physical therapist, you should be empowered to ask questions. Don't wait to be told things, but if things don't sound right or you don't understand, you should ask questions. And you should also tell them things. Don't wait to be asked, but if things are bothering you or you're not sure about something, you should tell them about it. Don't minimize it, and don't wait and wait and wait. The second thing is to take care of yourself. It's okay to put yourself first because you really can't take care of others unless you are in the best shape that you can be. It's important to know your numbers, but I think that people equate numbers with, I need to know my blood work, or I need to know my cholesterol. And even though those numbers are important, there are other numbers that are also important. Numbers like your blood pressure and your weight and your body mass index, which is based on your weight and your height, and your risk factors. And there are calculators that your provider can use to help calculate your risk of diseases. And those are some numbers that are just as important, if not more important, to know. You should know your body because nobody knows your body the way you know your body. So don't be afraid to know your body, touch your body, examine yourself, know about your breasts, skin moles, look at them, see if you think they're changing. Take care of your eyes, your hair, your teeth. And if you're not comfortable with what your body is telling you, then those are concerns that you should bring to your doctor. And then it's really important to know your family history. Some people are estranged from their family, or some people don't have those personal conversations with their family members. They don't feel comfortable, but it is very important to ask your parents, your brothers, your sisters, oh, did you have a colonoscopy? What did it show? And you're not prying, you're inquiring because their colonoscopy results impacts you because it's your family history. So you can ask those questions if you tell them why you're asking those questions, and it's important information for you to know. So, why are we focusing on women? Shouldn't everybody be well? Well, yes, but women are more likely to be caretakers. And because of that, they'll put others first. They'll take their kids to the pediatrician to get their immunizations. They'll take their elderly parents and family members to their appointments, but they'll often then neglect themselves. But just remember that being a martyr never kept anybody alive. So it's okay to put yourself first at some point. The second thing is that role modeling is a powerful thing, and many women are the role models for their families and particularly for their children. And I always think of the song Cat's Cradle, the cat's cradle, where the boy grows up to be just like the dad. He goes away to college and comes back, and he never has time for the dad because growing up, the dad never had time for him. And so he grew up just like me, right? So you need to think about what kind of role model you want to be. Do you want to be a role model where you're not taking care of yourself and you're not happy and you're not healthy? Or do you want to show your children and others around you that, oh, it's okay for me to take this time for myself? And so maybe we won't eat dinner at 6 o'clock. We'll eat dinner at 6:30 because I'm going to take a half an hour and take a yoga class or take a walk or do something for myself. And believe it or not, for the most part, most people will accept that and actually support you in that because you're doing something that's helping yourself. As I mentioned before, nobody knows your body as well as you. So get to know it, find out about it, and then don't be afraid to ask or tell about symptoms, because a lot of symptoms that people think are a normal part of aging are not a normal part of aging. Things like fatigue, tiredness, poor sleep, urinary incontinence, mood changes. Those are not just a normal part of aging. They might be an indication of something that can be taken care of if you talk to your doctor about those things. So, I just started at Northwell several months ago, and I'm getting bombarded with people who are coming in for their quote annual exam. And where I was before, that wasn't such a big deal. And here it's all the rage. And so I made me ask myself, well, what is the purpose behind an annual medical examination? Because I know that over the years, I've followed the literature, there's really little evidence that going to the doctor once a year, going to the gynecologist once a year, going wherever once a year actually improves your health. That's not really what the purpose of your annual medical exam is. It's actually an opportunity, a great opportunity to talk to your doctor, like I've been saying. Go for counseling. You can counseling about diet, lifestyle. What should I do about this medication, about this ache and pain, about the fact that I can't sleep? And it's a great opportunity by going year after year to establish and maintain a relationship with the provider you trust. Because again, if you trust them, you're going to be comfortable telling them these things or asking them these questions. And so attention should be paid to preventive screening that's appropriate. It's not a one size fits all. You just get a card at age 40 and say, go for your mammogram, or you get a card at age 50 that says, go for your colonoscopy. No, every individual is different. They bring risks to the equation that are different. That's why it's important to know your numbers and your family history. And so targeted checks and targeted screening appropriate to your age, your family history, or whatever other things are in your history, that's what's appropriate. And those interventions are much more effective than just going for a gunshot sort of, picture once a year. So patients call me, it's interesting. I've sort of blown my mind a little bit in the last couple of weeks. They'll call and say, I have an appointment coming up in 2 weeks. Do you want me to get my blood work first so I have it when I'm there? And I can't imagine how I could order blood work on a patient without seeing them first, because I want to talk to them. I want to get to know them. And I want to make sure that if I'm going to get blood work or some other diagnostic test, some x-ray, something, I am going to do it in that targeted way. So I'm going to see them first, get their medical history, assess their risks, assess their preferences, and then decide what testing are we going to do today. So although many people think of quote physical, my quote annual physical means, oh, I'm going to get my blood work, or why am I not getting an EKG or a chest x-ray or urine every year? The most important part of a quote annual physical is actually the history part. The history where the doctor talks to you and you talk to the doctor. That is critical. And I don't think that lay people know that if you have a problem, doctors make the diagnosis using the history about 80% of the time. The physical exam adds maybe 10 or 15% of sort of confirmatory information. Oh, I think this is diabetes, or I think this is this. And then blood work just often just confirms that. But the majority of, as a physician, what I figure out is happening with the patient, and what I decide is the best course of something to be done for the patient comes from the history, talking to the patient. And so just like routine exams have not been shown to improve health, routine tests have not been shown to provide useful information during an annual exam. Targeted testing, yes. Oh, it sounds like you might have thyroid disease because you have all these symptoms. I'll get a thyroid test. But just randomly getting the same blood work on everyone is really not helpful. So what should we be doing? Well, I just saw a 28-year-old in the office this morning, and she says, oh, I haven't been to the doctor in years. And I said, it's okay. You're 28. You're healthy. So between 20 and 40, you can go to the doctor every 2 to 3 years, provided you don't have a disease like diabetes or some chronic illness that you need to be seen more frequently. Or if you have a problem, you could be seen more frequently. So the follow-up intervals will be based on what your doctor finds. Once you're over 40, it's more likely that you'll benefit from an annual exam because it provides that opportunity to talk about lifestyle. Things start to change with your body. Things start to change with what hurts and what doesn't hurt, what works and doesn't work. And so this is an opportunity to talk about those things with your doctor. So what should we be doing? What are those targeted tests? Well, we should do a cholesterol check every 5 years. That's the recommendation, not every year, not even every 2 years, because cholesterol is pretty stable and it's mostly genetically determined. And so it really doesn't change year to year unless you become maybe a vegan or a marathon runner and you completely change your lifestyle. Your cholesterol is going to be relatively the same. Now, if I'm treating your cholesterol with medication and I'm monitoring it, then I'm most likely will be checking it more often. We do diabetes screening in higher risk individuals. And I hate to say this, but now that many, many more people fulfill the criteria for overweight and obesity, and more people are sedentary, and more people have high blood pressure and some other risk factors, we're screening more and more people for diabetes. There are some recommendations to screen everyone over the age of 45, and some recommendations to screen people over 45 who have some of these risks. You can discuss this with your physician. We also ask, or your physician should be asking, and you should be telling them at every visit, do you drink alcohol? How much do you drink? Is it a safe amount? Do you smoke? Do you want to quit? Can you help me quit? Other drug use, marijuana, other street drugs, anything that you might want to talk about that could affect your health. And then there's going to be age appropriate cancer screening. So I'm going to do different things for a 38-year-old woman than a 58-year-old woman than a 45-year-old man. It's going to be different and it's going to be appropriate. So screening should really be a shared decision between you and your physician. We live in a country that's a little bit, I would say, paternalistic and maybe litigious. And so doctors do more testing because they think patients expect it and or they're worried they might get sued. In European countries, the amount of screening that's done and the amount of testing that's done is much, much less. And patients are not dropping like crazy over diseases that we're treating here. They're doing just as fine. And so a screening test should not be considered automatic, because I don't think people understand that every test that's done, be it a simple blood test or a CAT scan, every test has pros and cons, has good reasons to do that might be helpful and beneficial to the patient, and reasons to not do because it might be harmful or risky to the patient. And that conversation should happen between you and your doctor to say, is this test worth it? Do the benefits for me outweigh the harms that might happen? So should I have this? And then if that's the case, how often should I have it? Should I just have it once since it's maybe not that beneficial and maybe a little harmful? Or should I have it more often because I'm at higher risk? That's where the risk assessments come in. So tests do not keep you healthy. Tests just assess you at one point in time, right? So people get a false sense of reassurance sometimes, I think, because they went to the doctor, they got their tests and their tests were normal. Well, they had their mammogram and that was normal. Great. That means that day that you had that test, you didn't have breast cancer or you didn't have an abnormality on your test. It doesn't mean something can't happen to you in 3 weeks or 3 months. And I'm not trying to scare you. I'm trying to help you understand that the testing itself doesn't keep you healthy. That's why it's important to know some of your risk numbers, because we can actually positively impact our risk, lower our risk of diseases, and then be less likely to have diseases. No matter what the blood test shows today, I want to make myself healthy for the rest of my life. So these are some things to think about. There are some cancer screening tests that actually do sort of prevent cancer. So pap smears for cervical cancer screening can find cervical cancer in a very early stage or a precancerous stage. So yes, that can prevent full-blown cervical cancer. And a colonoscopy can take out a polyp, which is a growth that could potentially eventually become cancer. So you could prevent cancer in that way. But those tests are few and far between. Mammography doesn't prevent breast cancer. It just tells you I don't have breast cancer today. So I just want you to not put too much stock in the tests and put much more stock in your control of your health, because that's the most important thing. So what other screenings should we be doing? Well, like in the office this morning, we screen everyone for depression and alcohol. And those are questionnaires. Those are not blood tests or any tests. I ask you questions to screen for depression. And I ask you questions about how much alcohol or other drug use you might be doing. And we shouldn't underestimate, as I said, the history. There are many diagnoses like depression that there is no test for. I make that diagnosis based on the history, on the symptoms that you tell me you have. That's why it's important for us to have a relationship where you feel comfortable talking with me. We're now testing everyone. There used to be an age limit, but now we're testing everyone for hepatitis C and for HIV, because both of those viruses, which are chronic and can cause debilitating disease long-term, now have very, very effective treatments. And even hepatitis C has a very effective cure. So it's worth it to know if you have it. And often you may not have any symptoms, because if we find it, we can help you. Sexually transmitted infections, we screen as appropriate. So what is appropriate? If I have a patient who's 23 and has 3 sexual partners, I might screen him or her more frequently. And then if I have a 45-year-old who's in a monogamous relationship with her husband, it's just her and her husband, and they haven't had sex with anyone else for years, I might not screen them. And then you turn 50 or 53 and you have a divorce, and now you're dating and you're going out and having new partners, then I might screen you again. So again, it's not a one size fits all. This age I screen you, this age I stop screening you. It's what are your risks? Let me assess your risks. You have to be able to talk to me and feel comfortable telling me what your activity is, so I know what your risks are. In older women, we assess functional assessment, falls and safety. Is your home safe? Are there things in the home that could help you be safer to prevent you from falling? Because falls in the elderly can be very devastating if you get a hip fracture associated with that. We do bone density screening, usually at age 65. Many people get it done earlier, although the recommendations are not to do that unless you have high risk, unless you're at high risk for osteoporosis. And again, you could talk about those risks with your physician. And then we may do thyroid testing in certain select individuals as they get older. I always ask my patients, do you go to the dentist and the eye doctor? Why? That's not in my realm, is it? Well, of course it is, because your eye health and your dental health are very important to your overall health. And so for patients without risk factors, the American Academy of Ophthalmology recommends a comprehensive eye exam about every 5 to 10 years under the age of 40, a baseline at age 40, and then every 2 to 4, and then 1 to 3, and 1 to 2 years as you get older and older. And you don't just go to the eye doctor because, oh, I can't see, it's blurry, or my glasses don't work. You go to the eye doctor and they screen you for glaucoma and cataracts and other retinal diseases. And so it's important to get a good eye exam to make sure you don't have those other diseases. And risk factors for eye diseases include a family history of glaucoma or macular degeneration, a history of diabetes, a history of some autoimmune diseases, and then certain medications can affect the eye. Again, that's why it's important to know your family history, and it's important to talk to your doctor about these risks. People have underestimated oral hygiene, but we have learned in the last couple of years that a clean mouth is important for overall health, proper nutrition, speech, and social interactions, but also there are studies linking dental health to heart and lung infections, to heart disease, to stroke, and even some forms of cancer. So the American Dental Association recommends at least an annual dental exam for everyone. And then the frequency of follow-up is going to depend on what they find. If they want you to come more often for cleanings because you have periodontal disease or you need some cavities filled or whatnot. But don't neglect your dental health. Unfortunately, many insurance companies may not cover this, or it may be a different coverage. And maybe your practice, your doctor, your institution, I know Northwell has dental clinics and ways to have people come where they don't have to pay all the amount. There's a graduated amount of paying. So it's not something that people would neglect as much because of the financial disincentive. So it's important to go for a dental exam. Okay, I'm going to talk about obesity for a little bit as a serious medical condition, because it is. And we've recognized this, but unfortunately it's still considered sort of with a lot of judgment and sort of stigma. But obesity is a medical condition just like having diabetes, like having high blood pressure. And you can see on the left side that obesity identified as a BMI, that's your weight divided by your height of 35, your body mass index. US adults, about 42% of them have this degree of obesity. So this is the percentage of adults in the US, and both men and women, they're about 42% have a BMI of 35. Severe obesity is defined as a BMI of 40 or more. And women have almost twice the rate of severe obesity as men, 11.5% versus 6.9% for men. So this is a particular concern in women because obesity can be associated with many, many medical problems. It's a risk factor for developing many cancers. Look at that. You're worried about, I missed my mammogram, do I have breast cancer? But did you know that certain cancers are actually associated with obesity? And that weight loss, as little as 5 to 10% of your body weight, can actually lower these risks. So it's not just getting the test to say, I don't have that disease now. It's saying, what can I do to lower my risk from never getting that disease in the future? So breast, colon, and uterine cancers are associated with obesity, as well as fatty liver, which we've called non-alcoholic steatohepatitis, or steatohepatosis, fancy medical terms, or non-alcoholic fatty liver disease. But just know it as fatty liver, which can lead to cirrhosis, which is terrible. But it's completely preventable and avoidable or fixable to a certain point if obesity is associated with it. We know that obesity is related to diabetes, hypertension, stroke, and heart disease, and other symptoms like urinary incontinence and sexual dysfunction. So again, the things that you might not want to talk about with your physician. Now, most of obesity is genetically related. It's actually more genetically related than breast cancer. So you have to look around your family, and if your family has obesity, then you're likely to have it. That's unfortunate for you, but it's not inevitable. You can work on it. There are many medications nowadays and surgeries and other treatments that can really work on obesity and help you. Many of the new diabetic medications also result in weight loss. And so we've been using them for that indication also. So there's really a lot of new therapies, and it really is something worth thinking about because, again, just 5 or 10% of weight loss. So if you weigh 200 pounds, you don't have to get down to a svelte 125 or 30. You need to lose 20 pounds of that 200 pounds, and it will make a large difference in your risk for developing diabetes and some of these other conditions. So it doesn't have to be a large weight loss. Okay, so let's talk about cancer screening, okay? These are the 3 main cancers that we're going to talk about for screening for women, because these are cancers that have been shown that screening is effective for decreasing the finding the cancer at an advanced stage versus an early stage, and also for dying of the cancer. These are the ones. We now have some emerging data for lung cancer, and which I'm not really going to talk about, and we'll talk about some other things later on. So colon cancer is currently under discussion about the age to be screened, but that's something that all women should be screened for. Breast cancer as we get older, and then cervical cancer, usually in younger women. So these are the society recommendations for cervical cancer screening. And I know this is a little bit of a busy slide, but I just wanted to point out a couple things. So the U.S. Preventive Task Force Service is a government agency composed of no subspecialists. So these are people who are generalists, family medicine people, epidemiologists. They have no vested interest in any particular cancer or program. The American Cancer Society, obviously, their goal is to find cancer. The American College of Obstetrics and Gynecology obviously has a bent. And then the American College of Physicians is internists. And so you could see that they're pretty lined up in terms of their recommendation that you should begin cervical cancer screening about at age 21, and you should stop cervical cancer screening at age 65. So cervical cancer screening is a pap smear. So that means you can stop getting your pap smears at age 65. If you've never had an abnormal pap, you don't have cancer up till 65, it's unlikely you're going to get cervical cancer, you can stop screening. And the recommendations vary a little bit about how often you need a pap smear. Most of them say you need a pap every 3 years, or a pap every 3 years, or a pap with a test for a virus that can cause cervical cancer, the human papillomavirus. If they add that to the pap test, then it can be every 5 years. And many of these are the same, 3 or 5 years, which means you don't need a pap smear every year. In addition, all these groups recommend that if you've had a hysterectomy in which they've taken out your cervix, so now you don't have a cervix, so you can't get cervical cancer. And if the hysterectomy occurred for a non-cancer reason, like you had fibroids or you had heavy bleeding, then you never need a pap smear again because there's nothing to smear. And so some docs will continue to say, oh, we should just check, but there's nothing to check for. In addition, there's no evidence to support doing a routine pelvic exam, that is, going to the gynecologist or the doctor in the years between when you're getting your pap. If you're not getting your pap, just to have a gyne exam. There is no indication to have that gyne exam, to do a rectal exam, to do an abdominal exam, to do a bimanual exam. If you don't have symptoms, if you're not complaining of vaginal discharge, or it hurts when I have sex, or it hurts when I pee, then there's no reason to do a gyne exam, a gynecologic exam, if you're not having a pap test as part of that. Okay, so let's talk about breast cancer. That's a hot topic. Everybody worries about breast cancer. Again, this is an opportunity to talk to your provider about what are your risks, and then identifying, are you high risk, middle risk, or low risk? Because it shouldn't be an automatic recommendation for everyone to get the same screening test if your risks are different. These are the risks for breast cancer, and they're divided into categories. So these are the patient characteristics. Now, we can't do anything about our age, right? And breast cancer increases with increasing age. So what I see is 45-year-olds who are worried about getting breast cancer, and I see 75-year-olds who are like, oh, I can't be bothered going for a mammogram anymore. When in fact, that 75-year-old is much, much at higher risk to have breast cancer than that 45-year-old, simply because she's 75. We can't do anything about our height, but we can do something about our weight. We can do something about our physical activity, and we can do something about our alcohol consumption, because even 2 drinks a night increases your breast cancer risk the equivalent of if you had one first-degree relative who had breast cancer. So think about, rather than just worrying if I'm ever going to get breast cancer and I don't want to miss my mammogram, think about, do I have risk factors that are actually things that are under my control that I can do something about. So the family history is usually first degree relative, mother, sister, daughter. So don't come to the doctor and say, oh, cancer all runs in my family and everybody has cancer. I'm going to ask you who and how old were they when they were diagnosed. The age of diagnosis is very critical, okay? Because if my mother got cancer when she was 82, she got cancer because she was 82. That imparts no additional risk to me whatsoever in my risk of breast cancer. Now, if my mother got breast cancer when she was 42, that's much more important in terms of conferring a risk to me because it's an early age. And then if you have other related cancers such as endometrial, which is uterine, cervical, colon, again, you need to know about these in their family. Your reproductive history is very important. You can't do anything about when you had your first period and probably nothing about when you had your first child, but those are risks for breast cancer if your periods were very early or your first child was very late. You also can't do anything about when you go through menopause unless you've had surgical menopause. And again, the later your menopause, the higher risk of breast cancer. We have modified the use of hormones, but hormones turn out to be not so great a risk for breast cancer as we once thought. And then breastfeeding decreases your risk of breast cancer. So if you have the option to breastfeed after having a child, you might want to do that option. In fact, there's some emerging data that breastfeeding decreases your risk for stroke and heart disease 30 years down the line. Okay, breast characteristics you can't do anything about. If you have dense breasts, a prior biopsy because there was some abnormality that they found, or benign fibrocystic disease. And women who've had radiation because maybe they had thyroid cancer or lung cancer or Hodgkin's lymphoma in the chest area, got radiation to the chest. This makes women very, very high risk. But most women fall into the category where they have a few of these, and that makes them moderately high, average risk or slightly above average risk. So maybe 1 to 2% risk of breast cancer over the next 5 years. And some of these, like I said, you can actually do something about. So these are the recommendations for breast cancer screening, and we do breast cancer screening by mammography. Excuse me. I took most of the same organizations. I added the Academy of Family Physicians because many people use a family provider as their primary care provider. And I put in the American College of Radiology, excuse me, because they do have a vested interest in mammography. And just to show you what the difference is of different organizations. You can see even these, though, are pretty in line, that they recommend the age to start screening to be 50. Even the American College of Obstetrics and Gynecology, for whom many of my patients see a gynecologist and get a paper when they turn 40 that says, go get your mammogram every year. Even they recommend individualizing between the ages of 40, 49. What does that mean? That means what I've been saying this whole talk. It means knowing your risks, assessing your risks, and then deciding if the benefits of a screening test outweigh the harms. And then we stop screening at age 74 only because no studies have studied women who are older than 74. But all these organizations agree that if you're 75 and you're a good 75 and you're likely to live another 10 years, or you're robust enough that should cancer be found and you could have a lumpectomy and radiation and you could tolerate that, then you might continue to screen for breast cancer into your 80s. That is an individualized decision. The only way you can make individualized decisions is to have that conversation with your physician. So some of the recommendations then vary on the interval, just like we talked about pap smear intervals. Many say you can have it every 2 years because as you get older, the cancers that occur are less aggressive. And so you can still pick them up, getting mammography every 2 years instead of every year. And you get less radiation when you get a mammography every other year instead of every year. Some say every year, some say talk about it. And the American College of Radiology starts at 40, says yearly, and continue for the rest of your life. Well, I don't think that that is appropriately thinking about what the patient would want. That's truly a one size fits all. In addition, there's no evidence to support performing a breast examination without symptoms for breast cancer screening. So even though your doctor will likely do a breast exam as part of a gynecologic exam, to be honest with you, some of that is related to billing and tradition. We used to do that as tradition. Now, women should examine their breasts themselves because they're the ones most likely to know their breasts, just like I told you, to know your body. And should something happen, you're going to be the first one to pick it up because you're going to feel something different. Then you can bring it to your doctor's attention and they can do a breast exam. But doing screening breast exams is really not been shown to be very effective. And it really doesn't pick up things that the mammography is not going to pick up. So colon cancer screening is currently being updated. And so everything I say today might be different in 3 months. There's a recent updated recommendation by the American College of Gastroenterology to begin screening everyone at age 45, whereas prior to this, the age of screening initiation was 50. And some of those organizations that I put on the previous slides, the United States Preventative Task Force Services, the government agencies, are currently looking at the data to address this question. And they are probably also going to recommend starting to screen for colon cancer at age 45. The best screening tests up till now have been a colonoscopy, which is a test that requires a preparation where you drink some liquid, you clean yourself out, you go to a gastroenterologist, they put you under twilight anesthesia, you have a tube put up through your rectum that looks at your colon. If your colonoscopy is normal, you don't need another one for 10 years because colon cancer grows through these slow stages, just like the cervical cancer, through precancerous stages. And so if they don't find anything, it's unlikely you're going to develop cancer in 10 years. The next new emerging test is this stool immunochemical test called a FIT test. And that again is currently, I've seen 2 recommendations, one for it to be every year and one for it to be every other year. It's currently being looked at now. And this is a nice alternative for someone who doesn't want to have a colonoscopy, for whom the prep is too difficult. For my elderly patients, it may be too difficult, or you have to get someone to drive you to the test and drive you home because you've had anesthesia. So the FIT test might be a good option for you in that case. The thing you need to know about a colonoscopy, and the reason why you need to ask your brothers and sisters if they've had their colonoscopy what it's shown, is because if it's shown a polyp, and a polyp is just a small growth, you need to know, 1, how many polyps did I have? 2, how big were they? What was the size of them? And 3, what were they under the microscope? What was the histology? So after you have your colonoscopy, the gastroenterologist will often talk to you. You'll still be in twilight. My patients tell me, oh, he told me something and I was out of it and I really couldn't remember. So you need to make sure that the next week, after the pathology report is back, you either talk to the gastroenterology office or your primary care doctor's office and find out, 1, if you had a polyp, 1, how many did I have? 2, how big were they? And 3, what were they under the microscope? Because those 3 things will determine when you need your next colonoscopy. If you had multiple polyps or very big polyps or very abnormal polyps, you might need a colonoscopy in 3 years or 5 years. If you had 1 or 2 small ones, you might need another colonoscopy in 5 years or 7 years. And again, if it was completely normal, you don't need another one for 10 years. Other tests that are not as good are flexible sigmoidoscopy, a CT colonography, which is like a CT where they put the dye in your colon, or even a stool test where they send you home with 3 cards to check your own stool for blood, and you send those back. And the issue with these are they're not great tests because they don't really look at the whole colon as well. And if they're abnormal, then you still need a colonoscopy anyway. So that's why for most of us, the default has been to go for a colonoscopy. Although, like I said, this FIT test is going to be maybe a game changer for some people. So the risk factors for colon cancer is if they have a family history of colon cancer or polyps, like we just talked about. If you have a history of inflammatory bowel disease or radiation to your belly, just like radiation to your chest can be a risk factor for breast cancer, radiation to your belly can be a risk factor for colon cancer. Certain genetic cancer syndromes. So if, quote, cancer runs in my family, I'm going to ask you, what cancers? Were they breast cancer, ovarian cancer, uterine cancer? Because there are certain groups of cancers that run together in genetic predispositions. Other cancers, which are still bad cancers like lung cancer and pancreatic cancer and liver cancer, don't necessarily run in families, don't run together in groups. And so even though it's important to know your family history of my father had liver cancer, maybe he drank too much alcohol or he had some other issue, he had hepatitis C and he got liver cancer from that. That does not necessarily put a risk for you. And so once your physician looks at all these risks, the testing and timing of your colon cancer screening will vary. So for some people at high risk, they're going to start to get screened before 45, maybe at 40, maybe at age 35. So these are important information. This is important information for you to know. And again, that's why the numbers you need to know are your risks and some of these numbers about polyps. So what shouldn't we be doing? What do we do in this country that's a waste? We do a lot of waste in this country in terms of healthcare. We do it in the name of trying to help people, but it doesn't necessarily always work out that way. And so, as I told you before, routine tests should not be done. You're not routine, you're unique, you're individual. And so your doctor should individualize what testing he or she does for you. So don't feel bad. Don't feel like your doctor is not doing a good job. If, oh, I didn't get an EKG every year. I didn't get a urine test this year. Doesn't mean your doctor's not doing a good job. Doesn't mean you're getting bad care. It means you're getting thoughtful care and appropriate care and individualized care. We would love to be able to screen for ovarian cancer because ovarian cancer is a devastating disease that often takes women in their 40s and 50s in the height of their lives. But we do not have a screening test for ovarian cancer that is safe and effective. Despite this, many people will screen for ovarian cancer by doing bimanual annual exams, by doing ultrasounds, and by doing some blood tests, none of which have been shown to find ovarian cancer sooner or affect the outcome. So women aren't finding metastatic or advanced cancer, or they're not dying from it. None of those tests have been shown to make that difference. And in fact, several studies have shown that these tests cause women to get unnecessary surgery because someone thought they felt something on an exam or thought they saw something on an ultrasound, and the women went for surgery, and lo and behold, they did not have cancer. So they went for unnecessary surgery. So that's why you don't need an annual pelvic exam, especially if your doctor tells you the reason they're doing the annual pelvic exam is to screen for ovarian cancer, because it's not effective. Routine labs, as I mentioned, there's no routine labs. I'm going to do blood work that's going to be appropriate for your complaints, your risks, your lifestyle, your age, your preferences. Similarly, rectal exams we used to do for colon cancer screening. We used to do a rectal exam as part of that. We also used to do rectal exams as part of prostate cancer screening for men. We no longer do rectal exams for prostate screening for men because they've not been shown to be effective and they're uncomfortable and intrusive, so we stopped. We also do not do those for colon cancer screening. One rectal exam to check your stool for blood on that day does not screen you for colon cancer. And if your doctor is doing it, and you should ask him why. And if that's the reason, then that's not an appropriate colon cancer screening test, because I just showed you what are the appropriate colon cancer screening tests. So these are not things, and they're not comfortable. And so this is why I mentioned at the beginning that you should be empowered to understand what's being done and why. You're not insulting the doctor. You're not being impertinent. You're being empowered to take control of your body. You may still opt to have these tests. You just should have them after you are informed about, well, why are we doing them? What's the effectiveness of them? What's the potential harm? What could it otherwise do to me that's on the bad side, not always on the good side? So that's a lot of information. I hope it was clear and got you to think about taking control of your life and your health. My email is on here, so if you think of any questions, you could feel free to email me. Just maybe put in the subject line, you know, the library lecture, the Oceanside Library, so I know what it's related to. And I would be happy to address or answer any questions or concerns you have. I encourage you to go out, be empowered, ask questions, and be healthy. Thank you very much.
Thank you so much, Doctor. I'm going to end the recording here before we start questions.
Okay, great.